everyone. Can you hear me?
Yeah.
Okay.
Yeah.
So my name is Valerie Hoy, and I live in the U.S. This initiative, this health and wellness initiative, was something that was birthed out of the need for health education in Barbados. And to give the backstory, one day some person said, you have to watch this show about Barbados. I really didn't know anything about politics in Barbados. I didn't know anything much about what was going on in Barbados. But I went to the show, and I think at the time she was being called the most controversial woman in Barbados of the year or something like that. So I go on the show, and the first day I go on the show, I noticed that there were some things happening at our hospital, QEH. And I go like, well, there's some things that I can do. I think that we can teach people what we need to do. I've certainly worked in HIV and AIDS, I've worked in mental health, I've worked in medical services, I've done all of that. I was the director of a program in New York City for several different programs. And so I had a concept on how we needed to provide services. In addition, I had the resources in terms of the friends that I had and who I can reach out to. One of the doctors that we wanted to have here, she wasn't able to travel. But I had Rosalind that I've known for over 30 years. I had Brenda that I went to school with. We both went to primary school together, we went to high school together, so I knew what it is that he knew in terms of his work. And so what we did was that we reached out and Rosalind actually said there's some person in Barbados, and he's pretty dynamic. He is really, really good at what it is that he does. And she said, you have to reach out to this person and you have to talk to him about maybe coming on board and being part of this. And so I reached out to him. I had to do it a couple of times, and I think the first time I got a response back was like, who are you? Right? And I go like, okay, well, Rosalind tell me to call you. She said, you're good at your job, right? And so when he heard what it is that we were doing, he said, I think that is something that I would want to be a part of, right? So we have Mr. Gaskin on here, and he says, okay, I'll get a few other people that I think is amazing and wonderful. And so he got Dr. Lovell, and Dr. Lovell got Victoria, and then it birthed this whole idea of healthcare, this health education initiative. And so at this moment, we have Mr. Gaskin, along with his fantastic team, who's really going to talk about, healthcare and how we can go about, assisting and helping Barbadians to take care of their health. Now, one of the things that happened a little bit earlier, and we noticed that we have, I think one of the credit unions talking to you about, financial wellness. And to me, that is one of the big things, right? Because people tell you, oh, when we talk about health, we talk about the medical piece, we talk about the mental health piece, but we don't really talk about the financial piece. And financial wellness is one of the key things that's going to happen because it makes a difference in the type of medical care that you're going to get, right? And so that is key, that if I have to teach every person in here, whether you're a grandparent or you're a parent, I would say to you that one of the things that you want to do, even if you cannot do it for yourself, you should do it for your child, your grandchild. Start teaching your children how to invest and manage your money, because again, as they get older and things start to happen, you want that if they have to seek medical care, they can finance their own medical care. So without further ado, I'm going to turn this over to Mr. Gaskin so that he can now talk to you about, what we're going to be doing today. So thank you.
Good evening, everyone. Thank you. Good evening. Again, good evening.
Yes.
Yes, great. Welcome to our panel discussion on men's health. Why the emphasis on men's health, and also in my conversation with one of my concerns and one of my main advocacy goals is to really kind of bring men closer to the healthcare system. Research has shown that men have very poor seeking behaviors, and we see that quite evidently here in Barbados. And despite we are saying men within the context of the poor we're speaking to, we're speaking about health generally, but I would expect that we would submit a little more on some specifics related to men and some of the cultural transmissions that might impede or impact on men actively engaging in our healthcare services. But before we get into the discussion, I just want to look at healthcare in a broader context, and it's according to the World Health Organization, men on average live 6 years less than women. Women are living longer than men. This part is largely driven by higher rates of non-communicable or NCDs, as you would know them, such as heart disease, diabetes, and certain cancers, as well as mental health issues and risk behaviors more prevalent among men. Globally, suicide rates are significantly higher in men, and many are reluctant to seek help on mental health concerns. And as I indicated earlier, the situation in Barbados very much mirrors the situation globally. So we have to really, within the context of our Barbados situation, respond to these challenges by ensuring that we have the appropriate initiatives that will motivate our men to have better seeking behaviors. And this evening I have a group of persons who is more than capable, they're well established in their respective fields, and we are going to have a hearty discussion with you. I don't want you to sit and just listen. If you have the urge to ask a question, feel free to raise your hand and we will entertain your question, because this is about sparking something within you and have an eagerness or willingness to ask a question. Unfortunately, we don't have as much men within the audience as we would like, but I'm very sure every woman here is affiliated with a man, be it a partner, a husband, a son, an uncle, or one of these relatives, or boyfriend or partner. So this information will be most useful, and we would like you to go back and share this information. On my far right, I have Ren Lewis, a registered mental nurse. His passion is committed to improving mental health care access and combating stigma. I have Rosalind Paulus, a registered nurse in New York, specializing in chronic illness, diabetes, hypertension, and depression. I have Rendell, let me give you the reviews. I have Dr. Laura Lowe, a medical doctor specializing in non-communicable diseases, and she will discuss the prevalence and management of these conditions. I have Victoria Cox at the far end, a nutritionist, and she will speak to the role of diet in men's health or in general health, helping clients develop healthy relationships with food, particularly the diabetic and hypertensive client. And on my immediate left, I have Linda Greenwich, a registered nurse, a nurse educator with advanced experience. He's based out of Canada, and he'll be focusing on hypertension and kidney disease. Together, we will sit and explore and look to see how we can optimize on the health-seeking behaviors and the activities of general migrating public with emphasis on men. I'm going to just pose a general question to the panel at this point, and I want each one of my panelists just going to make a comment within the context of their respective specialties and what they're observing. What is the most pressing health issue facing men in Barbados today, and why do these issues persist? Brad, we'll start with you at the front.
Good afternoon, everybody. So, what's the most prevalent pressing issue as it relates to men in our Barbados society? And that can be very many, because it's pretty complex, it's not singular. As Gaskin alluded earlier, our health-seeking behaviors as men generally, we don't like to go to the doctor, we don't like to take medication, but at the same time, we like to look and feel good, which is kind of our best. So we sometimes find ourselves challenged with societal norms and expectations that we are supposed to be weak, we are supposed to go and be physically broad, make money, and take care of families and homes. But something that comes with an expense, and that's taking care of ourselves. When we pour into our families, our communities, and our societies, we're actually training ourselves. So there is a need for us to reinvest in ourselves, and that's like going to the doctor and first acknowledging that something is going wrong with me, that maybe something at work, a position that I may be going after, or that as you know, making up with headaches daily, that something pathologically may be going on. So the step is to move from acknowledging what has started, then to move into figuring out what is actually going on. So we are challenged with this perception that a man is supposed to be physically brawn, but what about the emotions? We are not encouraged to express our emotions in public forums, at homes, at work, or anything like that. So if we are worried, if we are not understood, we're supposed to just shut up or sweep the issue under the carpet, so to speak. But what we don't understand is that this translates to what we see in society, and we wonder why there are so many men at God's prison. Because when we don't express our emotions, it actually finds a way out. And it expresses as anger, violence, aggression, and we see it all the time, out of being not understood. So I encourage all the men, obviously, to express themselves. And it's not a sign of weakness, it's actually a sign of strength. That you can actually say what it is, because you're more self-aware as to who you are and what is going on with you. And when you become self-aware, you're grounded in yourself as a person, in yourself as a father, in yourself as a community leader, in yourself as somebody that can be respected. When you neglect to understand who you are, you become whoever the person that is looking at you, whatever their perception of you is. That is somebody that is not good. Somebody that is of no use. Somebody that will amount to nothing, as we would say in our Bajan vernacular. No use, we would internalize that. But if you have a purpose, then you can exude that purpose onto persons, into your society, and feel a sense of fulfillment, a sense of accomplishment, a sense that, you can be a part of something that is actually bigger than yourself. So when a person asks me about mental health, when we get more into that, is that men have three tenets. It's about what you think, what you feel, or your emotions, and then more internally how you behave and act that as well. So take a situation, case in point, let's take an example. So you're at work and you're vying for a position, and Rosalind is vying for the position, and Rosalind gets the pick. We were both at the same level, but she emerged to be successful. I'm more qualified, more experienced, but to my mind, she's more favored, and she got the position. So today, she was my equal tomorrow, she my boss, she don't tell me what to do. So my thoughts about her is that she did not favorably or upon merit got that position. So when I think these things, these automatically evoke some emotions in me. I either become jealous, I become conceited, when she gives me a direction, I for sure ain't following the direction. And then, because then that's going to translate into how I don't treat myself, how I treat myself as well at home or at work. So I start following or not following instructions from persons. So you see a short chain of catharsis of events that becomes negative because it starts at the genesis of how I begin to think. So when we start changing ourselves at the level of our thoughts, then we can start changing how we treat persons, how we start feeling about ourselves, and again, how we feel in the presence of others and allow others to view us as that, as a person as well. So that's where we have a good set of work to do as men, and I hope to continue this conversation soon. Thank you.
I'll repeat the question. What are the most pressing issues facing? I know you're not from, you're not being limited by this for a while, but in terms of your experience, what are some of the issues you see that is particularly challenging for men within the context of healthcare and health-seeking behavior?
So in the US, we have, when a man is diagnosed, whether it be hypertension, diabetes, or any of those diagnoses, men are they don't take their diagnosis well. In terms of their medication, They don't want to take the medication. They feel useless as a man. Depending on the medication they're given, they feel like, well, I can't perform sexually, then my woman is going to look at me like I'm a failure. So a lot of times when people are diagnosed with hypertension and diabetes, they refuse to take the medication because it plays a role in their sexual function. What we try to do is educate them that, the medication will help you. But then they go into the depression piece because they feel I can't really provide for my wife, my girlfriend, whatever it is. A lot of the times, people when they're diagnosed, they don't want to hear that word medication. They would rather go and take herbs. They'll tell you I'm not taking the medication, and we find it most in men. Some women will say, I'll try. Men will say, I ain't doing that because, it's going to affect me. I can't, go to work. I can't have sex. I can't do this. And most of the time, it's the sexual part. So they become depressed. They're afraid to go home and tell their wives or, their family have been diagnosed with, this condition. So we try to educate them. We try to do a lot of preventative medicine in our practice. So we educate the men. We try to make them take the medication. So I think that men should, open their minds to treatment because the treatment is good for you. At least you live to be with your family. So that's my takeaway that, a lot of the times education is important, but also men, we need to come out of that phase where we're in that taking medication is going to affect us. If you take the medication, you have a better chance of being on this earth with your family.
Well, I agree pretty much with what the panel said. So I'm going to take this through two different lenses. So I work on the acute side of nursing, and my white counterparts, and white men, their approach to healthcare different. They're very open to having a conversation with the medical team, whether it's psychiatry, whether it's dietitian, whether it's physio, or whether even if they intend to it. They're very proactive with their treatment and their care. Similarly, on the black side, I find that we have challenges with a lot of black men. Black men don't want to take the medication. As far as, especially as Robin said, as far as sex is concerned, there's always that problem. If they take this medication, like sex drive will increase, or I don't get erection. They choose not to have conversation with you as the wife is happening. They talk about, oh, I'm going to be able to have sex with my wife, I'm not going to take medication for having that. You try to educate them as much as possible, and they wouldn't accept that education. I see it a lot in the Caribbean community, and I see it a lot in the African community with Black men. It is really, really challenging, because if they would only take the medication and understand why you take the medication, or spin it on the other side and say, okay, well, you can take herb, natural, vitamins, and stuff like that. It would help with it to just don't want to hear that. They're taught not to be emotional. So there's a challenge that's going on with them. And you said, okay, well, have you had a conversation with your wife or your kid? No, I don't want them to know what's going on with me. It's none of their business. So you can't provide the education to the family so that they can have a conversation with their loved ones. And I find that really challenging with my community. We have done a lot of outreach, a lot of education, and we refer them to the family physician. We give them a lot of information to take home so that they can comply with the medication and still know. Around hypertension, men don't want to take the medication for hypertension because if they're okay, well, women are supposed to do this, I'm not supposed to do that. We are taught Black men not to be emotional. And then we shared the story early on that when there was a young kid born by grandma told me, if you cry, I'm going to be the shit of you, sorry for that word. And I adopted that and I transferred that into my bloodline, right? and I see us in behavior, right? I took a different spin about 10 years ago, and I hope that this session today, right, we would educate you guys, focus on awareness. If you have any questions, reach out, ask.
Question?
Ask as much questions as possible. And when you leave here today, we want you to be informed, right? And reach out to your family physician, reach out to your dietitian, a psychiatrist, whatever the case may be, educate yourself and become informed. And that's my takeaway.
Hello? Yes. No, I think that we have a different perspective because both Victoria and myself practice locally. We both practice within diabetes. And I think that as it relates to men, the men that we're needed to reach are technically men who are not here. And that's a hard one because men who are generally not health seeking. So they're not going to go and seek about their health care. In fact, they're not going to come and go for their annual screening. They're not going to come for every little pain to the doctor. It's only when something they think is wrong or they think that they're going to die pretty much that they're going to come to the doctor. That's what I get in practice. So when a man comes as a walk-in, it's an emergency. Because men don't come unless they're brought like their girlfriend. Their wife told them this is a problem. We need to come and see me right away. That's when a man comes. So again, the men who are going to seek about their health care, ask questions, know what is an A1C, know what blood pressure even means. Those aren't the men that you have to worry about. It's the other men, the men that are not going to come, right? And I think it's about trying to figure out ways to meet them. And what works in one culture doesn't work in every culture, right? I'm a big proponent on culturally sensitive ways of education, and I think that flyers and stuff isn't necessarily working in our population. What patients always say is one-to-one. So everybody's story gets told. So, oh, I went and the doctor told me this medication is no bad. No, everybody's gonna say, oh, you heard about metformin bad, and everybody's gonna spread that story. So everybody's bad story gets spread around to the next person, right? And that doesn't really go for men, that goes for women, that goes for everybody. That's how we learn in our culture. We learn by storytelling, it's been a historical thing. We learned about, oh, did you hear that soursop leaf was good for this? No, everybody in the community is using soursop leaf. Soursop leaf off of the trees. Yeah. That is exactly what happens, okay? So I think not only as it relates to men, but men, women, everyone who has any chronic illness. As I said, diabetes is the number one thing. You have to be able to meet them where they are at in terms of education and understand how to explain history and education in storytelling. So the same story that you give to somebody else, or how you would teach your children or whatever, that's how you teach education in terms of medical diseases. So I'll give you one to think about. I always say medication is like deodorant. If you put it on yesterday, it's not good for the next day. Right? So that's one that most patients come back and tell me, oh yeah, I remember you said medication is like deodorant. Because I wore my deodorant yesterday, I got sweaty, and therefore I need to have my deodorant the next day. And medication is the same way. So you need to take it every day because it's like deodorant, it's a bath, you have to take it. So those same stories, yeah. Okay.
Excuse me. You weren't saying that metformin was bad, were you?
No. That was the story of the week. The story of the week was, oh, I heard that metformin coming in from India, that bowl was bad, and it came on and sent out a WhatsApp message, and we learned things more from WhatsApp than we learned from your doctor sometimes. Right? So, yeah. I'm sure Victoria has equally interesting stories.
Thank you. Yeah, I feel like I agree with everything that everybody has said so far, and to touch on a piece of every part of what everyone has said. So even from Dr. Lovell's perspective, a lot of times patients, especially men, don't really want to come to the doctor to begin with. I'm sort of second tier to that. I can only grab them when they're coming to the clinic because they've been to see the doctor and they're already there. And they think, okay, great, while they're here, let's have a nutrition consultation. Because if they're just coming to see me, they're even less inclined to show up. I mean, certainly the patients who come for a nutrition consultation who are men, if they're electing to come, I use that word strongly, they're usually brought with a female family member, as in the female family member is bringing them, books the appointment for them. And I think there's different reasons, especially from a food and nutrition perspective, because nutrition is related to eating and therefore cooking, which is maybe seen as more a traditionally feminine sort of area. I find especially men who are maybe single or living alone are particularly uninterested. They feel, they just kind of live life buying food, minimal cooking, don't really feel like it's something that they should concern themselves with or have time to concern themselves with. I certainly see also, which again, I think was Roslyn who said, like a lot of the men not wanting to go on medication, which is an interesting conversation because they'll say to me that they don't want to go on medication, but then if they're not particularly interested in changing their lifestyle and their eating habits, where do we go from there? Realistically, men and nutrition, I don't even know where to begin. I feel like I spend most of my time, they come usually with questions, I guess, when they do actually get to me, much like Dr. Lovell said, in terms of, well, I work long days and, they're gonna take, I'd say, bush tea instead of medication, but then when they get tired throughout the day because they maybe have a physically demanding job and they need energy, they're drinking sweet drinks all day long. And not that is specific to men, but in particular, because a lot of men may have more physically demanding jobs. I get that. You need energy, you need something quick. The logistical thing of meal planning and shopping, again, is seen as more traditionally feminine. It creates a lot of challenges. So when possible, although I think it's great to empower and educate men on how within their family situation, or whether they live alone or not, that they can figure out a way to eat healthily. If family members are involved, that realistically can be helpful as well. But yeah, basically kind of mirroring what everyone has said so far on my end, I guess.
Question, yes, sir. Go ahead.
Yes, I want to executive question. They wanted to know, are there other interventions that can be used alongside the medications to assist and help heal the body? Supplements, herbs, etc.
Okay, was this a man asking this question?
This is actually a woman, Cecilia Green.
So, interesting question, and I hear at least 25 times a week. Why I say interesting is, if you're doing traditional medicine, we're going to do traditional medicine via certain, is a very calculated way, okay? Extra things such as supplements and so on, people can use them. Everything has its place. As you can see, I'm picking my words very carefully. But I have a question to you guys. How many leaves of bay leaf must I use to lower my blood pressure from 140 down to 120 and not carry it any lower? How many cinnamon sticks must I use to carry my sugar down from 8 to 4? We have no clue. That's the answer, okay? So when you boil your aloe and your cinnamon and all these things, yes. So Susie might see that my sugar going down from 8 to 5 and I feel better than ever and using cinnamon. You gotta use 3 sticks. What was good for Susie is not good for Bob.
Yes.
right? So whereas things like, whatever these general things, the genital work is one for inflammation. The soursop leaf pig, pear leaf, lemongrass concoction, whatever is trending in that moment, because things have their waves, everything has its waves as these stories evolve. But the truth is that there is no science to them. And I'll give you a little story about the moringa. Remember when moringa was back in fashion back in 2015? Everybody was coming into King Clinic with their moringa seeds, okay? Meaning that too much moringa was causing all these people to have end-stage kidney disease. So again, we don't know how much. So Susie may have used it and not had any. It wasn't like everyone, but I'm just saying that certain things do have their detrimental effects. Okay? I'll give you one that is local. What is our national flower? Pride of Barbados, right?
Yeah.
Did you know that Pride of Barbados is actually used or can be used to cause abortions? So if you eat the flower, you can actually get abdominal spasms causing an abortion. But somebody else might use it and say, well, use this for whatever, abdominal pain. Oh yeah, you cut me very good. So you do not know that this has other effects, okay? So always talk to your doctor and have that conversation if you're thinking about using alternative methods. There's no supplements, no herb, no nothing that I think is superior to any course of therapy, anything that you can discuss with your doctor. It has to be an informed decision, okay? And as it relates to feet, especially the persons with diabetes, please don't focus any focus on your feet. Those things actually have no weight. So that is not like the other bits with the joint symmetry, hold on, right? But again, culturally relevant, because I'm not sure if anybody here is from St. Lucia, but in St. Lucia, you use cinnamon after you have delivery because it's supposed to get rid of the extra blood after delivery. It's just a cultural thing. Again, you can actually cause hemorrhage, right? So that's why I said those things have to be discussed with your doctor.
Fact or fallacy? Does the drugs or the hypertension drugs cause erectile dysfunction and impotency?
It is a fallacy, not a fact. So what actually causes erectile dysfunction in vented hypertension is your arteries. In the arteries, you have a buildup of plaque. And you guys probably are aware of high cholesterol. And that's what the buildup in plaque is. So it decreases the flow, right? So it decreases the blood to your sexual organ, and that is what causes actually erectile dysfunction. So you need to take your antihypertensives. The alternatives that you can take, such as pomegranate. Pomegranate are high in antioxidants, and that gets rid of all the extra free radicals that's floating around in your vessels, right? And that can restore blood to your sexual organ. But that's just fancy, it's not that. Take your antihypertensives. Questions?
I'm curious to ask the panel in terms of, because I got the feeling that men they have seen beers are very poor, but then those guys who actually approach the healthcare service then don't go home and reveal to their families that they're having issues in terms of what they've been diagnosed. But I do subscribe in some instances to the shocking and the awe of a particular circumstance for persons to realize the gravity of the seriousness of it. So in terms of men who approach the healthcare facility late or the doctor, what are some of the situations that are happening? Is it extremely traumatic for them there? Because there are no let's put it, you alluded earlier to depression with chronic illnesses and CDs in terms of those revelations. Are we seeing men who are not handling
these diagnoses and becoming extremely depressed or extremely angry that Randy alluded to in terms of your experiences?
I don't think it's a men thing. I think it's anybody with a chronic illness. If you think about it, the decisions that you have to make, again, going back to the diabetes, every day with having any chronic illness, it's something like 50 decisions. Did I eat right? Did I take my medication? Outside is awful, I got a little bit of sugar. There's so many different decisions, and there's a whole different branch or complication, I want to say, that goes along with diabetes called diabetes stress. So actually feeling the mental health we on you of having any chronic illness, right? Because think about it, you can't wash away diabetes, it's there, okay? So I don't think that men, unlike women, get more angry. I think that they just handle things differently. So men might not talk about it, some men just don't deal with it, some men do deal with it and do it like, oh, so they take their medications, they come to the doctor, everything is fine. I think I agree with you that persons from, well, I have more European than US persons, but European white males or European males, they are generally different to Caribbean males. A Caribbean man is not going to come and want to open up to you in the same way and not be as prescriptive with their management. The Europeans be like, give me everything that there is on the market. I don't care how much that is. I want to live as long and healthy as possible, right? So I think that that's different. But one thing I do is encourage anybody, man, woman, whoever, to come with a relative or somebody that they want there. Because you cannot go and call, you know, your husband got X, Y, and Z. You better check him on that. No. So you just encourage that person, you know. You don't always remember everything, just bring somebody with you who can help write down stuff, right? That's usually what I do.
Yes. Yes, ma'am, go ahead.
Is there any side effects from the medication? And what if we receive the leaflets from some medication to show if there's been any side effects?
Everything in life has side effects. Let me just say that. You can calibrate the side effects as either negative or sometimes even positive. But we usually fix the length of negativity as we use the word side effects. So whatever decision or like choices we make will have a pro and con to it. And that's where the discussion needs to occur at the level with you and the healthcare provider. So the side effects may be something as simple as data androgynous, which can still translate to something more serious, especially if you operate heavy machinery as a man, or even if you're a lady and you do the work, you can cause yourself injury. But the conversation needs to happen as it relates to where you don't get relief left in the medication package. I can't quite answer to that, but as you open the package and it's not open, ask for it, and then again, Dr. Love spoke about having a support system and having somebody there with you. And so that somebody not only understands what your diagnosis is, but also understand what your treatment plan is as well. So once that person knows what's going on with you, and let's say your symptoms deteriorate to a point, they also know best how to assist you. So that they call for a 111, that they don't just say, my 76-year-old grandmother, she's not doing well, and you can say a little bit more about that person, or the person takes metformin. And they also take amlodipine as well, 5 milligrams once in the morning. And you can be more surgical, and they use the word as a figure of speech, in how you address the person's situation. But what we find from a health perspective is that we like to live in quiet corners, although we are part of a family. And yeah, you know my name, you know my date of birth, but when you walk more, you know about me. And I'm speaking about not just friends or extended family, he's talking about persons that actual relationships as well. Husband and wife, yeah, you know, he's that's a medication, but I know what it is. And we got probe, and the doctors and the nurses will have a lot of queries to what it says. So for us to make a meaningful impact as healthcare providers to you, the person seeking healthcare, we need persons to one know about what and way of what they're doing at this level of health, and of course, what treatments and how we can best help you, because that can expedite along the steps to mitigate outcomes. That could be the difference of you having a longer life without injury versus, having to say rest in peace to somebody, God forbid. But from a mental health perspective as well, as it relates to that, being diagnosed with any medical condition, be it a common flu, has a psychological component to it. You start automatically thinking, if you're 50 decisions, Dr. Lewis spoke about what my quality of life is going to be. I can't miss a day's work. Need about change what I got to eat. Maybe I can't have a put in a sauce on Saturday morning. I can't get to the drum shop at the corner. You start to go through all these things that will be enjoyed, because food, as Victoria will probably tell you, and support me, is that we eat a lot for taste and not necessarily for nutrition.
Yes.
We eat because of the taste and how it makes us feel. But then it's interested, you got to put more greens and all your portions should be this much vegetables and fruits, nuts and pulses. You start looking like, who me? But it forms part of a larger continuum of issues and a cascade of issues as well, because you find that healthy eating too has an economic value to it.
Yes.
So it's quite easier to eat a lot of processed foods than tinned foods, because they are all obviously easier accessible, they're cheaper. But what we end up doing is causing ourselves an injury. Yeah, we're eating, but are we being nourished? It's a question that we see before that and answer. So when you eat all the put in a sauce, with the nutritive value that we're getting besides the increased plaques that Wendell spoke about. So when you're really saying about you're concerned about erectile dysfunction, you're placing the blame on the antihypertensive medications, you really got to look to Victoria and our level and speak about your diet and your decisions about what damage is that you are incurring on your body. And then you realize that you can't get up, because many as a man, we afraid of our manhood, and maybe you can't get up, you feel inadequate. So when we feel inadequate and we go in the bedroom and we got our thoughts, because sex and sex relations begins at the end of the money. Because once they find you appealing and you know about I want to have coitus today, and they go in the bedroom and they just robe and everybody pour me champagne, the lights dim, the ambience created, and they realize that the end of movement happening down below. Then it really takes a spin us to what Marlene said, we really ain't getting it on today.
Yes.
Right? And the only thing that getting on is that I probably getting on your nerves, meaning you see, I have got to have this relationship with, but I cannot perform. And then that can be reciprocated and you feel lesser of a man. He probably could take the social media and say, believe where Lewis, he can't get up, he professes to be this muscular person, but look, he can't really get one minute up. So it really costs us. So this really seeks from the directional and causal relationships of mental health and physical health. So when we speak about health, and then last this activity, we speak about health in generality and not as silos. So when you go to the doctor and speak about health medication, and hoping that doctors also explore the possibility that when they diagnose you with hypertension or diabetes, that they also pan in about who you feel now having been diagnosed with this condition, and they offer a certain hope that this is not the end all to you. You can still live a productive life, but yeah, they may got some changes, but we need to take some 6 steps to make these changes so that you can still be much of who you have known yourself to be.
Yes, and to answer our question, to respond to your question, Laura would have suggested earlier that we have certain cultural practices and beliefs, and I want persons to appreciate that you are a consumer of the service, and that when you go to seek that service, you have every right to make a query. Do you have this available for me? Do not push me out of this office. I'm paying you. And we need to empower our health seekers that as a consumer, you're purchasing a service, and in purchasing your service, you have every right to ask the question and demand that you get a response. So really and truly, in terms of our cultural responses, there's some areas that we have to really kind of break and empower our health seekers into appreciating and understanding that you are a consumer of a service. And in consuming that service, the person who's offering that service have every right to answer your questions. Are you fighting right? Right? I just wanted to make another quick point. I'd like to come in now to when Ryan said, and he challenged our colleagues here on the stage, and he's saying that in mental health, we're trying our best to reorientate our medical practitioners. You would see that when we go to the polyclinics, it's very easy for somebody to come over from general into psychiatry. But we want them to really begin to appreciate that, mental illness isn't as sensationalized on television. In all instances, you have mild, moderate, and severe presentations. And sometimes a simple diagnosis of hypertension, we need to really change that orientation more and have a conversation with mental health persons, because you have to make a lifestyle change that might cause you to spiral. So we're inviting our colleagues on the general side to engage our mental health services and feel free walking persons over to access our services. Yes, sir.
Hi, good evening. Yes, just wanted to make a comment to what Richard said. Sorry, I can't remember your name. Ryan. Yes. Yes, I really want to very honest to what he said, because in his family, there was an instance where one person was diagnosed with cancer, and they didn't take the news too well, and subsequently they didn't live too long after. Then there was another instance where another family member, they had cancer, and they were able to sort of a link to each other, so and how we take this information plays a big role in terms of how we recover from certain things, or even if we recover from certain things. My grandfather was also one, so when the doctor told him he gave him 3 days, or let's say a week home, he stays home for 3 days and he's back out to work again. So how we process these things mentally takes a big factor in how we recover too as well. Even though in terms of myself, sometimes when you get sick and you have a fever, you're not feeling too well, you just lay down in bed all day, you don't do anything, you just feel sluggish. And your mental state is about it takes me longer to recover rather than if I know I have something I have to get done, and I know that I've got weakness, then I really tend to recover faster. So thank you for making that correlation.
Good evening. My question will relate to actually all members of the panel. One of the things that keep coming up in the discussion is culture and socialization. And I want to know, and in fact, what I should say, how all of this impacts on our approach to mental health in particular. And I want to know from you, to what extent do you think we need to engage psychology from a Black perspective, Black psychology, or forensic psychology? Because we have a lot of problems with the Black community and so on and so forth, and you raise a lot of them. So to what extent do you think a shift in the psychological approach to mental health and to social and economic problems generally, broadly speaking, to what extent do you think that is important?
Right. I'm an educator, and what we're doing, like what the doctor said, is in terms of, as we prepare healthcare providers, we're preparing them to appreciate this diversity among us, and that we offer culturally sensitive care. And it's a big thing now, that you have to be acutely aware of who is in front of you and what is the cultural drives, the norms, the mores, their beliefs and their value systems, because more and more you're understanding that these are having implications with the way persons respond. And I normally give an example. I'm 70 years old, not literally, I'm 70 years old, and I've never been to the hospital. I go before this nice looking doctor, and she says to me, Mr. Gaskin,
you have to take this, you have to take that, and I'm very responsive to that at the time. But then I go home into a community where and I've never been to hospital before, and I've been sick for my 7 years of existence. I've been sick, and I've been using pomegranate, passion fruit, soursop leaf, and I've been surviving. But now in this particular instant, I'm in hospitalized, and this nice looking doctor comes over to me and says, I must take this. I'm in agreement with her. However, when I go home, my grandmother, who's been helping me now for the last 70 years, said, don't take that, that is nonsense. Yes. And believe me, who am I going to hear? I'm going to hear my grandmother. And my grandmother is my mother, my aunts, and all them survive. And that when the doctor got down in the office, sorry, doc.
And to see me, his grandmother, mother, got him to reach the age 70. He asked him to take a medication. So he asked him to take a medication, he reached the age 70. So he started to conflict what the doctor is saying, which has credence and merit, but he also is weighing that against something culturally that he's grown accustomed to that allowed him to reach the age 70. So you start to question the validity of what is being told now versus what I have experienced over the last 50 years. So we just think the decision is going to be.
I'm going to ask Victoria a question. Victoria is sitting on here by herself. In terms of, I've heard things about food pyramid, I've heard about the nutritional plate. And can you kind of just share some information on that so that there's a practical use for persons in terms of eating healthy?
Yes, I gosh, I mean, so well, the food pyramid is, I think that's an American tool that they use in terms of healthy eating. Barbados does have its own food guide. I do not use it. I try and make, when I'm approaching the talking about making healthy changes, healthy eating changes with somebody, I try and make things as simple, uncomplicated as possible. Because it's already been sort of spoken about, we eat because we enjoy the taste of what we eat things that we like, we eat things that are convenient, we eat things that are cheap, we eat things that are nearby. But usually it's not all about eating for health and wellness, right? So there's a lot of changes that have to be made, and people automatically start thinking, I mean, people's minds run way ahead. So for example, if I say to somebody, maybe we can talk about decreasing pork intake. Now what they're automatically envisioning is that they're never going to eat pork ever again. They're never going to have bacon again, they're never going to have sauce again. Like all they said was talk about decreasing it a little bit, right? And they are like jumping way ahead of me, so they don't even want to like make that next step because they're envisioning maybe what I might suggest at the end of the road. So I try and keep things as, I tend to use the tool called my healthy plate, which is, it's as cliche as you've ever seen in your life. It's a plate divided into a quarter of your plate being a carbohydrate, a quarter plate being a protein, and the rest vegetables. And I just call it the 1, 2, 3 strategy, and I go through each food with, with my clients, and I think I try and let people know right up front that there is more flexibility than you would think in terms of healthy eating, even for persons with diabetes or hypertension. I'm not a super, I tell you what you can. I say that to all of our clients, I'm not here to tell you what to do. We're both adults. I'm here to explain this is the effect that something has on your body. So I try very hard not to be emotional about good food, bad food. When somebody asks me about a specific food, they say, is ice cream going to raise your blood sugar? And I say, I think you know the answer to that, but that's great. I'm not saying ice cream is bad, but it's full of added sugar. This is going to move quickly, into your bloodstream and spike your blood sugar. So I try and break foods down into just kind of their components and how that will affect the body, and therefore food we should have more often versus less often, rather than just kind of blanket statement calling things good or bad. Because as I said, I think a lot of people, even when they do come to see me, they have preconceived notions of what I'm going to say. They think, Victoria is just going to spend the whole time telling me things I shouldn't eat or can't eat, when I try and have a lot more emphasis, in fact, on the things that you should eat more of and how you can achieve that in a realistic way and still eat things that you enjoy. But yeah, I definitely know that, because people make a joke of it, they come and sit down in my office and say, yeah, you already ate that, it's gonna tell me what not to eat, right? And I say that's really not the case. I may be trying to tell you what not to drink, because sweet drinks are the one area where I'm probably a little bit more inclined to be, I don't want to use the word strict, because that's not it, but stick to my guns. But it's a lot more about learning just how food affects the body, and maybe you need more of it instead of less of it, to be honest. Yeah, but I do tend to use that healthy plate tool for the most part.
Another picture of someone who uses a lot of herbs and so on and so forth, came down with a bulge in the kidney area and having maybe minor kidney difficulties, and I think also affecting the liver. How serious is that in your estimation?
Okay, so not really sure what bulge in the kidney area is. Really not sure what bulge in the kidney area is, because the kidneys are actually behind, protected by a lot of things, okay? And based on that or any other story like that, you cannot make a clinical diagnosis, okay? Any practice of clinical medicine, meaning going to a doctor or a doctor, not Google doctor, because I'm sure when you clinical symptoms in Google, it's going to tell you have cancer, and live 6 weeks, and you need to get chemotherapy at this hospital. So that's why I said, going to a doctor is a full history and examination, followed by the required investigations before you make any suggestion of the diagnosis. So, like that, you cannot tell what that person has. I don't know what mild kidney disease is, I don't know what bulge is, I don't know what liver impairment means. All of those things are things by themselves. And it could mean nothing or it could mean everything, right? So, as I said, clinical medicine, which is what I practice, not Google medicine, is made with a clinical history, relevant examination, and required investigation.
So you understand the warning the dear doctor just issued, Dr. Google is a problem.
Yes.
You all know that, right?
Yes.
And very often we go to Dr. Google and we make all kind of diagnoses, and then we predict all types of outcomes. And even more so, we then go looking for strategies and interventions that would cure and take care of everything. And we assume that this journey would heal us before actually going to get the consult from a medical practitioner. And these are some of the practices that are causing some very serious problems within our space. I want to ask Wendell, though, in terms of working with persons with kidney problems, and we've heard the term end organ damage when persons have diabetes and hypertension and those sort of conditions. What are some of the signs and symptoms that men should look for in terms of urinary output or any of that?
Well, initially when a person goes into kidney failure, you still make urine. As the condition improves, you still make urine, but it becomes clear. And eventually, when the kidneys are dead, you make like 10 cc's an hour. So we need to be tracked with. The average person makes about 30 to 40 cc of urine per hour. And this is looking at it from a clinical lens. No, sorry. It's about a coffee cup. It's about a coffee cup. So that's pretty normal. The thing is though that our urine is not supposed to be sweet smelling. It's not to be concentrated. If it is sweet smelling, it means that you're diabetic. If it is concentrated, it means that you're either dehydrated or you're going into kidney failure. So some of the signs and symptoms that a guy can look for, your feet begin to swell. And that is one of the indications of acute kidney failure. And the progressive, they get worse. The other thing guys complain about a lot about is pain in the back. So as Dr. Robert said, the kidneys sit in the back, and they will complain of back pain, lower back pain. People might think, okay, well, I twisted my back, whatever the case may be, but that can be an indication that the kidneys are crapping out or the damage. So the message here, if you experience that, then you need to go to your family physician. You go to your family physician, he or she will do a thorough clinical history. They do specific blood work if they suspect, based on your clinical presentation, that this is what's going on. They might do imaging to see how big the kidneys are, right? They might also look at your blood pressure. I also want to, I also want to talk a little bit about this, because there's some blood pressure medications that we take. And this medication like Enalpro, and I'm not too sure if you guys are aware of that, and Captopro. And these medications are not to be used by Black people. In our and the reason why I say it, so there's certain antihypertensives, which is Enalpro or Captopro. These medications are not supposed to be taken by Black people. The reason being, our kidneys hold on to sodium, and as how to put this in the internet. So we have this thing where sodium goes, as you know, sodium is very concentrated, water follows. So you start blood pressure rising, right? We go to the doctor and say, give us these medications, and you don't question that. The Black community, we're supposed to be taking antihypertensive that protects the kidneys. But again, that message is not communicated to the general public. So in the white community, the kidneys don't hold on to sodium like the Black community does. Historically, the reason why we as Black people are so hypertensive is in the 40s and the 50s, the way that we preserved our meat was in brine. Versus the white community, they have fridges. So we ate the meat, and then it increased our blood pressure. We need also, going back to kidney disease, we need to, as I said, go to your doctor if you suspect this is what's going on. You got to find out, right? It's only one or two things that's going on. You have heart failure, you got kidney disease, or you got liver disease. You talk to LVLP, and that goes away, but that's not the answer. So you need to go to your family physician, to a clinical presentation, they need to do blood work, right? And I'm not going to get into the specifics of the blood work, but you need to do that, right? And the ARP, the fluid of the blood goes back to our heart, and we think we're fine. And actually the kidney is cracked, right? And when the kidney cracks, then we got the end result is dialysis, right? But before we get there, there are 3 stages of kidney disease. You got decreased blood pressure to the kidney, right? That's the first stage. So if you're dehydrated, guys, drink a lot of fluids. Drink water, to be precise, drink a lot of water, right? And don't drink 5 cc's of water. Drink, and not a gallon either, drink about 250. You just need to raise your blood pressure. Sometimes that's all you need to do, because then it jumpstarts the kidneys and you start to make urine. The other thing that happens too is most of us in here talk about water pills. And you take the water pills and ask you why you're taking the water pills, you don't know. Or the doctor say that I need to take this, but you can't tell me the name of it and you don't know the reason why you take it. Sometimes you take that, and that jumpstarts the kidneys too, and it makes you pee. Keep a log, right? Keep a log. And a lot of men in general, sometimes we get burning, and sometimes we get a little blood coming from the urine, right? And that's just a break in the blood vessel. That's not normal. So if you see stuff like that, right? I don't sit down at home and say, okay, you know what, I'm not going to do this. Tell your wife, tell your loved one, tell your doctor, go to the hospital, and have a clear presentation of what's going on. But, you know, the confirmation of that is by blood work, and we can do imaging of the back, right? And that's my thing on kidney failure.
I just hold for the question for a second. Laura just wanted to kind of.
Oh, no, I was just saying, some, I agree with some, not all, what you just said. Why I say that is, again, I'm practicing here. Right now in the polyclinics, there is no availability of certain types of blood pressure medication. So therefore, we have to use what is available. So yes, things might be first line and all these are great and all that, but at the end of the day, I want your pressure down. And I want it controlled. So I'm not gonna say, oh, well, you know, this is not first guidance for this area or this group of persons. So you have to use what's available. That's number one. Number two, kidney and eye disease may have no symptoms. So you may be feeling fine. People think that, well, why you have pain and back pain eyes? You're telling me I have bleeding and skin carcinoma and upper. Eye disease has no symptoms until it's too late. Okay? So for instance, with diabetic or hypertensive eye disease, both of them involve nerves and blood vessels at the back of the eye. And unless you are checking using a screening, which is you go to your optician or your ophthalmologist every year for the back of the eye screening, not vision screening, so if you have glasses, the back of the eye screening, which is called a retinal scan. Unless you have that done, you have no clue, right? And very often, at least again once a week, we find persons that have no idea that they have this done, that need to get somebody next, okay? Or injections or something, so to slow down the rate of the progression of it. Same thing for kidney disease. There is a place called the Farland Foundation here. The Farland Foundation, they have a clinic in Carrington Village where they do monthly kidney checks free of cost at the points of care. Both using the blood as well as the urine kidney check, okay? And every month, they find persons who have no idea that they have kidney disease, needing referral to either renal clinic or referral to hospital for renal management. So too often people wait until they have symptoms because they think, well, my feet are fine, I don't have back pain, I still pain, I have kidney disease. You don't know unless you check, okay? So as part of your annual screening, you should get your kidneys done, as well as the eye screening done. So yes, in some persons you will have kidney disease and have symptoms, other times you have nothing. I remember a case of a patient who had no symptoms, came here on vacation, and then she got very unwell. And it's not only one person, it's actually many people. Got very unwell and needed dialysis within 2 days. So again, she had no clue until the end, right? And right now, the renal unit at the hospital is our most expensive unit. So most of our health service budget goes into giving persons dialysis because it's a very costly exercise. And unlike other units, you don't discharge people. Those people are current people and they will be people until they await up events, right? Meaning that they pass on. So it doesn't reverse and get better and we discharge them and so on. They're usually a patient continuously until they're discharged back into their primary care, if so much. But I'm seeing now younger and younger persons. So again, people used to think, no, I can't have kidney disease, I'm only 25. I have people that are 21 with diabetes that are seeing kidney disease. So don't think that you're too young and don't not get screened because you don't think that you have symptoms, both for the kidney as well as the eye, okay?
But I really want to emphasize a point, right? So I practice in Toronto, right? And I see a broad spectrum of antihypertensive that we use, right? And like, I don't know the antihypertensives that are used here, but I'm really concerned with my community, right? and the antihypertensives that they're using, that contributes to renal failure. I'm very concerned about that. And I know the doctor spoke a lot about the clinic, I'm happy now, but I see a broad spectrum, and I see a lot of my black people come in, and they come in with certain medication, and we just stop those medications, and we use medication that will protect the kidneys. And that's really, 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 really important. And we don't ask questions when we go to the doctor, and we should. We should take a family member, sit and have a conversation. Okay, you ordered it. What is this order for? How is it going to affect me? How is it going to affect my blood pressure? What am I supposed to do? Am I supposed to be eating this? Am I supposed to be drinking it? This is the kind of message that I want to leave you guys with.
I'm going to take one more question, and after that question, we're going to take a brief pause for some announcements for terms of prizes. At that point, Laura and Victoria will exit. They have something pressing to attend. So just take one question and then you pause.
I have a question from online. Is it true that men with diabetes will affect their sexual prowess?
Yes, that was discussed. Men with diabetes can affect their sexual prowess.
It doesn't make sense. So your erectile dysfunction in men living with diabetes happens by two main mechanisms. So one is you have blood flow or lack of blood flow going from there. So the next way is that it actually can alter your testosterone or your male hormone. So that is why some men would come in and they went to the rum shop pharmacist. I think they did say rum shop pharmacist. And they would have been like, no, you need to take 2 blue pills to be fine. And the blue pills don't do nothing for you if your testosterone is low. So if your testosterone is low, you can use 10 blue pills and it's going to do nothing. Okay? So usually for screening, using an early morning testosterone reading as well as an ECG. The reason is if you have heart disease and you use those blue pills, then you will have some compilation events, which includes a heart attack when you try it, because using blue pills to give you blood flow there is going to give you blood flow everywhere else. A sudden rate, heart attack. Okay? So that's why those two things are important. And if you get testosterone replacement and you have, which is usually an injection or patch, and you do have heart disease, another heart attack for you. Okay? But the number one method I also say is that if you are a man and your waist circumference is greater than 100 centimeters, decrease that waist circumference, testosterone going up. Okay? So get a smaller heart waist, testosterone goes up.
You understand what the doctor is saying, that one of the concerns we have is with hip-waist ratio. And if your waist is bulging over your hips, you're going into that danger zone where you have things like low testosterone and you want susceptible to non-communicable diseases. So it's important that you try to keep your weight down, especially around your stomach area. One of the biggest indicators for chronic illnesses in men is that hip-waist ratio. Let's wanted to answer a question, Doc, before we pause this as well.
I believe you said that, if they come in to get a kidney screening, my question to you is, how do they go about it? Because most people would not say, I need this kidney screening. So for their annual, what is the blood work that is done and what should they be asking for?
One blood work that's done depends on what it is.
Okay.
Right. Once the blood work that's done depends on where they go, who they see, what tests are available at the time, if they have reagents for it to come back. All of those are usually the factors. For a couple months, we were doing common, but it was being done A1C at the hospital, there was no reagents. So if you were in that period, you had no idea where A1C was. If you, as I said, the Forever Foundation, so you just call their clinic, as with Saturday, they're doing the free testing, and they can organize free kidney testing, do both ACR as well as the blood kidney testing. And because they are linked to cells, which is one of the dialysis places here, they're able then to refer you to a kidney clinic because they have an arrangement. Right? But it's hard for persons to know what to ask for, because if you're living with diabetes, you don't use the word diabetes anymore. But if you're living with diabetes, you may not know all the things that you need to ask, but there are certain things that you need to ask. What are my kidneys like? When are you receiving my eye test? What are the vascular functions? Do they have an A1C this year? I think 3 months past, how come it didn't get with A1C? Those are things that we need to check for, right? And at least have a baseline ECG to know how your markers are.
We're gonna take a break now. Laura and Victoria will exit, but I just want to kind of reiterate something she said earlier. Using medication and using deodorant, that's very important. I love it. Can I have it? Yeah. And also another wise statement I heard many years ago. I heard that when you're diabetic, you treat your feet like you treat your face. You get that? When you're diabetic, you treat your feet like you treat your face. You wash it, you dry it, you examine it, you look in the mirror, and all these different type of activities. And with that, we're going to pause for a few. And we're going to busy up here a little bit. Y'all know what busy is?
Yes.
My counterparts from Canada and United States working from there with busy. We're going to busy a little bit. And we're going to excuse these two wonderful ladies. I might give them a round of applause. And thank you for being here and braving the weather. And it was a pleasure having you both. Thank you so much. All right. segue the conversation. You would have heard about the NCDs and you've heard about kidney and hypertension. But there's something with hypertension called vascular dementia, where as a result of your elevated blood pressure, you can have a decrease of blood flow to the brain. And as a result, we are seeing that dementia, especially dementia of the Alzheimer's type, is one of the leading type of dementias globally. When Barbados, we are seeing an increase in the numbers of persons who are suffering with hypertension, and as they age, they're coming down with this thing called vascular dementia. And for those of you who are not familiar with dementia, you can appreciate things like cognitive deficits, memory loss, not recognizing your own relatives, and then sometimes the behavior where you lack inhibitions and you say things like profanity and you accuse persons of stealing your stuff, that this is basically something going on with your brain that's altering your behavior. Everyone here is equipped to respond, so I will just leave it to the panelists to respond. I'm not going to pick on anyone individually, but I suspect everybody will have a say. Feel free.
Okay, so as Mr. Gaskin said, vascular dementia is about so blood pressure, let's go back. So blood pressure is the force of blood against arterial walls. That's what we measure blood pressure. So think about plumbing. If anybody knows anything about plumbing. So if your pipe is clear and water is gushing through it, you're going to have a normal flow. But imagine if that same amount of water is going through that pipe, about half of that pipe has a dump in it. What do you think is going to happen? Right, the pipe is going to start to swell because it doesn't have a regular passage per se. So it has something that's blocking it. So what's happening is because of that blockage, which is in the blood vessels, now it's called the plaques and fat, by the foods we eat, or the sweet drinks that we drink as well. What that is doing is affecting how our blood pressure is, because in narrow space, the same amount of fluid is passing through, you're going to get an increase in pressure automatically. So with that increase of pressure, you're going to lose elasticity into your vessels, or you're going to stretch it beyond its capacity. So dementia now is like when something with vascular dementia is that artery that goes to your brain, it actually bursts. So when that actually bursts, and depends on which artery it is inside your brain, it's going to affect some cognitive functioning that Mr. Gaskin spoke about. So it can affect your memory, it can affect your emotions, it can affect your motor skills, it can affect how you perceive reality. So your response to it as well. So things like making decisions, you can't get that done. If they ask you a question, you can look, some people refer to the response latency as you respond at all. You can look at people with a blank stare, like, who's this person? And they're going to look at the body person, like they're there physically, but they're not there. You're going to be wondering like, where or who this person is. But it almost becomes unrecognizable. So even to speak, their ability to speak, we call that expressive aphasia. So if I ask you a question, you're going to be telling your opinions and your words. That person's going to be saying something like that, but they cannot get out that response. But if they're good enough to be still physically well to the point that only that aspect is affected, but their physical coordination still remains with that. Something that person goes to what we call our middle response, and that's anger. So if you ever wonder why a person that is demented is aggressive, it's not really aggressive, is that they don't understand or have the ability to interpret your actions or the stimulus that they are presented with. So you may be trying to get them to sit down and get calm and so on. They're seeing it that you are harming them, or that you are taking them out of a cycle of death themselves, know something is going wrong. They cannot express it to you, the family member or the healthcare provider, but you're telling them to do something that they also do not understand. So if they try to get you to do something that you don't want to do, what's your first response? You're going to be resistant initially, so that comes back as a cyclic, you can get aggressive. But when you stop doing something and they keep doing it, your automatic response is to get aggressive. Yes, true, no?
Yes.
Great. So again, it also shows the correlation between mental health and physical health. So if you don't take the medications that mental is purporting or is purporting that is going to be a benefit to you, these are the other associated risks that you're also compounded with just your hypertension that can be managed with lifestyle decisions. Our budget yearly is heavily laden in management of NCDs, medications for diabetes, medications for hypertension, medications for respiratory disease like asthma. And you know something? Is that we still have an increase of insurgence of these diagnoses, something that can be managed with lifestyle disorders. We can easily say, oh, about lengthening medication, but there's another component, and that's about understanding what it means to you as an individual. That grief that Vanessa Valdes spoke about, as I said earlier, is a trauma when you get a diagnosis thing, when you start to wonder what is going to cause your life hereafter. What do I have to do? What changes do I need to impose on myself? What does it mean? If you're a child, can it play football and worry about getting a hard car for an or if I'm elderly, can it still keep the same job or do I have to remain enslaved? And you start to think worst case scenario or you think I'm supposed to blame. But each subsequent day that we decide, let me not use the word decide, that we do not or are not compliant with our treatment modalities that the doctors and the nurses insist on, is each day that your diagnosis or your prognosis of your medical issue gets worse. So the 2.5 milligram amlodipine that you probably were taking before, you start missing in a few days, then you're going to go to 5 and something going to get to 10. Or something you don't even have to add on something called diaphragm, or 60 milligrams. Or something you have to add a beta blocker because your heart rate up. Blood pressure will be coming down, but your heart rate still remains up. So you may have to get into Bisoprolol. And you may add on some other medications, and before you know it, every morning, sometimes 2 to 3 times a day, you are taking a monotone medication. Just so for you to understand, you're taking 10 different tablets. If you live in the first world countries, some of these tablets could maybe merge like Forge and have a cocktail so that it looks optically for the optic that you're not taking as much medication. Because if you start taking 10 and 12 medications, you start to internalize, and you'll be bad for the end of it. Things got to be real bad. And it also starts to affect you. It becomes cycling. And with this cycle, your health behavior starts to attenuate. And just to get back on course with vascular dementia, if it is you, the person that is caring for the person that has vascular dementia, then it also leads to stress and burden of you, the person that has to help. Being diagnosed with any medical condition, be it physical, mental, etc., it not only takes a toll on the client that has a diagnosis, but their support system as well. All right? And it goes from understanding how to help them, how to best assist them, and again about assisting yourself through that process as well.
Thank you. I just want to echo what Randy said, that when we embark on a lifestyle of indifference or as a personal health, as a result, we develop these not communicable and these very serious conditions. The burden then falls on whom? Your relatives, and they begin to inherit your bad lifestyle practices because now you are becoming what they call a burden. And mental health, very often we follow that. We see that a lot of persons don't see something called caregiver burnout. Really frustration, caregiver burnout. Really frustration level within a household. When a person within the household has a chronic illness, the burden becomes so heavy that there's a lot of anger, there's a lot of frustration, and I've actually had a client once who had an outburst while engaging with a mother, and she just made an utterance, why don't you just die? And then she was devastated because she made that utterance, but she said it out of anger and frustration, and burnout is real. Right? So I know as much as we're talking about you taking responsibility for your individual health, you also have to be like this young man. I don't want to put grandfather on blast,
But like this young gentleman said, that sometimes you gotta go and give grandfather a little nudge.
Yes.
Because I remember reading when we took the little break, I remember reading in the chat, a question was asked, how do we break this cycle? And it breaks it, that we have to really keep the young persons informed. And I don't want to say that some generations are lost, but there are some generations that their behaviors are so deeply entrenched, they're not necessarily going to change the behavior, but we don't want to lose a whole society or community based on practices that are very repeated. So we need to break the cycle, and we're ready to break the cycle with more programs like this one, more often, more frequently, where we can have some very candid conversations. And at the same time, we're really going to focus on the young persons. And we are working on ourselves as self-care practitioners. We're trying to reorientate our thinking, our approaches from some things that did years ago in medical school or nursing school. The science has evolved so much that we have to really keep abreast to deal with the changing environment for which we're giving our care. I just want to, we were here for a while. I just want to kind of, those who are online and take some questions from those in the audience at this stage. But we were talking for a long time, and there's a lot of information. So, any questions for us?
We have another question on me first. The person was asking, is the disease reversible?
So with diabetes, as long as you take your medication, there are people who are on medication and they take their regimen, so the numbers go down, the A1C can come down. I've seen people that they came off the medication, but I don't know about it being reversible, but it is treatable with lifestyle, being committed to taking your medication. So as long as you keep up with your A1Cs, take your medication, then you can see your numbers trending down as long as you follow your regimen. Maybe Wendell, maybe you can have something to say about that.
But it's interesting that you have a question, because it was at work last weekend, and I was speaking to one of the intensivists, and he said to me, have you seen this article that just came out? It was a 3-year-old kid, and she had juvenile diabetes. They went through the process, the A1C was consistently high, she was on glyceride and metformin. And 3 months after, they decided to do some blood work and stuff like that. The A1C came down to 4.3, and the blood sugar was peaking around 4.5 to 5, which is normal. And he said, okay, because he knew he was coming home to talk, and he said, you should speak about it. I said, you know what, there's really not evidence to support that. This is just one case, right? But I agree about it. We haven't seen a person that is diabetic and being reversed. The exercises, if you exercise often, it can help. It lowers your A1C, but once you're diabetic, that's it for life.
Can you just explain to the audience what is A1C? We've been using it a lot, so I just want,
Do you want to talk about it?
what is A1C? Because we've been hearing it. Are you all familiar with this term A1C? No?
Okay, so if you're diabetic, you usually do your A1C every 3 months. If your A1C is actually the level of blood sugar, or the level of sugar in your blood, and they measure it over a 3 month period. So if you are below 5.7, it's a normal A1C. If you have from 5.7 to 6.4, you're considered diabetic, pre-diabetic. And if you have a number above 6.4, then you're diabetic, and then they will start the treatment. So in terms of if it is normal, then you do your annual and so on, then, but if you're pre-diabetes, they will take your blood sugar, your A1C, every 3 months. If you're diabetic, they would give you start the treatment. But pre-diabetic, they usually talk about lifestyle changes, exercising, diet, eating right, and so on. They don't start the treatment till you are above the 6.4. So therefore, you have time to do those lifestyle changes and avoid taking the medication. I mean, sometimes you might have other comorbidities going on and it might not, you can try everything, but it might not work, but that's determined. So the A1C is just the measurement of blood sugar in your blood, sugar in your blood.
Question. What is the term borderline diabetes?
The term borderline diabetes is just you being pre-diabetic. So your numbers is probably above 5.7, and between the range of 5.7 and 6.4, then they will say you're borderline. So it's the same as saying you're pre-diabetes or pre-diabetic.
So to back to what I was saying, so my last A1C was 5.9, and my blood sugar they comes around 6.4. And they went to the GP, and he kept saying she was the one of you're pre-diabetic. This is what I need you to do. This is what I need you to do. Repeated my A1C at the 3 month level, and it came back at 5.9. And he said, okay, well, I need to put you on that medication. I said, no, because I'm not diabetic. I modified my diet, did exercise. I'm not as young as I used to be, so I went down around, you know what I mean, and do stuff like that. But I changed my diet one day, did some exercise, and he was happy with that because it's not easy for him to do the insulin or that medication when I'm not diabetic.
Okay, there's a question.
Good evening, ladies and gentlemen. What I have metformin. I've been taking metformin from how long? 1999, and I'm still on it. But each time I'm seeing a lot of things coming up about stop taking metformin. It is not good. What it can do to you, what it cannot do to you. I know there's the truth of fast release and slow release. Taking these fast release like they used to give me diarrhea and all that. Taking these slow acting, no, you don't get that problem. And then they're telling you now that after a period of time, it depletes vitamin B12 from your body. And so, how should you replace it, or if you have to replace it at all?
So if you're taking metformin, it really does decrease your B12. But your doctor should give you a supplement of B12. So you should take it once a day. And then you replace your B12. But it happens with metformin a lot.
So we would advise that when you go back to your doctor, you have that conversation with them. And you say, okay, well, this is what's happening. And you need to, be very coordinated and specific. And say, okay, well, this is what I read, this is what I was told. Can you add this to that? I also want, can you also add this to the medication routine? I also want to say that metformin, that also plays with the kidneys and it plays with your gut. So some people get a lot of diarrhea, they vomit a lot of metformin, but more importantly, it messes with your kidneys. So you also want to have that conversation with him, right? It's a very nasty drug, and it gets weakened everybody on the planet quickly. But this is not communicated to the general public. I really can't speak to what information is given to the community here. I can only speak to what I'm told. I'm not in the system, right? But when they look at the metformin, they can mess with kidney breakdown. So if you have that conversation, if you can have that conversation with him and let him look at the alternative medication, that would be good. I heard you talking about insulin, and I'm kind of surprised that you're on insulin and metformin, because if your pancreas is working, you shouldn't take insulin at all.
How I got on, I was taking 6 metformin, 2 lunch, 2 break, and 2 evening. and it making me sick. The doctor told me if I go on the insulin, I will come off the metformin.
But did he give you a reason as to why you need to go on the insulin? Because if your pancreas is working and it's still producing insulin, there's no need for you to take insulin.
So I opt to take the insulin, because the insulin was just once a day, rather than taking the
But
metformin.
did he tell you why? Did you ask questions why, or did you put it in?
I answer a lot of questions, yes I do. I answer a lot of questions. So what, now I'm now taking 2 metformin on morning and the insulin once a day. I started taking 40 units, and right now it come down. I'm only taking 35 units now of the insulin. And my last checkup, blood sugar good, everything good, and I don't have any problems right now. But I am still curious about the metformin. I thought I would have come off the metformin.
All right, we suggest that at the end of the presentation, you can have a conversation at the same. At this juncture, we will just take another 2 questions before we start to wind up this discussion.
Oh, yeah, thank you. My contribution now is not so much question, but a brief comment. I am really happy that I attended this session this evening, because this session confirmed for me one of the ideas that I have been forming recently. We have a very high medical bill here in Barbados, extremely high. And I think more public education programs like this need to be done so that we can reduce our medical costs. And I think our approach to medical care, and particularly mental health, needs to change. I think we need to approach it or see it from a cultural perspective. And that is why I think that we need to return or engage Black psychology so that we can really delve into the issues that are affecting us as a species.
We have another question from online. Someone asked, why are the credible studies and efficacy of traditional medicines not embraced so as to release the stranglehold that big pharma has on our well-being?
There's a movement now, the allopathic pharmaceutical methods. We're moving away now. There's a movement in medicine called complementary medicine. You've heard about it? Where there's a combination of the two, where medical practitioners who are operating in a particular space begin to value and understand and appreciate the indigenous treatments, and they engage in and having that conversation. So there is a movement where it's called contemporary medicine. But if you look around our landscape, you'll find that there's a lot of alternate methods that we utilize. For example, in mental health, there's spa day, there's exercise, there's stress relief. Some persons are going out to get massages and acupuncture, and those different types of treatments are being engaged, and there is some validity to them. I am not a professional practitioner in that area, so I necessarily can't speak to it, but I know that within our space, we're looking now at moving towards complementary methods that complement the pharmaceuticals that we are giving our patients. But it's a greater level of discourse and understanding that has to take place, but it is happening. It is happening.
What I want to also add to what Mr. Gaskin said, it's not directly medical, but it has some impartations on how we practice medicine in regards to, and that is the economics of medicine as well.
Yes.
As a nation, we don't have the level of access that first world countries do have. So you will have heard Dr. Level spoke about this is what we do have, and this is what we have to work with. So some things our ability to have choice and variability is lessened based on our economic footprint in the whole social strata of the world as well. So it makes no financial sense sometimes to bring our other drugs, or sometimes the cost is too high. So things that we didn't really pay attention to, things like the trade war between Russia and Ukraine, a lot of persons don't understand that Russia has about 8 of the fullest shipping hubs that goes to all the other countries around the world. So when that occurred, it really affected trade. And even coming out with COVID affected trade too, because there was the closure of borders. So these things that we don't pay attention to, they actually do affect how we have to practice medicine, because it equates to access. So we have to work with the limited resources that we have available. So it's not that all the other science in the country does not, we don't understand it, but when we look to measure against what we have access to, we are left with limited to no choice.
Are there any more questions? We'll take another one.
Online, someone asks or says, in America, you find that people are very comfortable speaking about mental health and even more comfortable speaking about their psychiatrists. Is this a cultural thing?
I suspect so. Proximity is a very serious thing when it comes to mental health. And Ram, moderator, Ram could speak to this with more, but I would really just kind of as a precursor. And because of ignorance, there's a heavy stigma. And many instances, remember when I spoke earlier and I said that you go to the hospital and you get this information, but then you go back home and you have to live within a community that have these negative connotations and these ideas and these perceptions of. And very often, how you follow when persons are discharged from hospital, have an encounter with mental health services, is we push back with the society. And this leads right into the campaign that we're actively engaging now with psychiatric hospital in terms of breaking the back of stigma. Because very often stigma is being pushed by ignorance. Ignorance. And I dare say sometimes the ignorance is expressed within the church, in terms of, I touched that one very delicately, because there's a lot of misconceptions that try to push against psychiatry. We are advanced significantly in psychiatry. Our ability now to image the brain and see what changes are occurring at the chemical level and electrical level is greater, and we can make some very reasonable assumptions based on what is causing some of the behavior presentations that we see with our clients. And I just want to make this last plug before Ryan speaks. Remember earlier we were talking about the elderly. And I just really want to kind of put this one out there, that when grandmother begins to behave a little forgetful or a little confused, we'll naturally assume that she has dementia. Take her to get a medical. It might be just a urinary tract infection or something that's going on with grandmother. So I really want to put that plug in there.
Yeah, thank you for that, Mr. Gaskin. So again, let me reintroduce myself. My name is Ryan Lewis. I'm a psychiatric nurse. I'm a mental health officer and also the program coordinator for an anti-stigma campaign that is currently ongoing, entitled Check My Bias. And what it seeks to do is to dismantle stigma and change, have an attitudinal shift as it relates to dealing and appreciating persons with mental illness. If I had to ask you what or do you have mental health, what would be your response? Any two persons. Do you have mental health? Yes or no?
We all have a degree.
So there's a dichotomy of understanding, because actually mental health is a good thing.
Yes.
Right? Mental illness is probably what you are responding to and what you have heard, but not what you have listened to. So again, I do crave your indulgence to change the thought process, and it has to begin with listening. We create narratives in our mind, sometimes unconsciously is supported by what we see in media, what we see on television and in movies. But I'm pretty sure you've read books beyond looking at the cover. Because you look at the cover and you realize, you probably tell yourself, no, this is not a good book, and I'm not so interested. But as you delve through the book, you realize that it piques your interest. And before you know it, you're at the last chapter, and you're wondering if it's a book 2 or book 3 or a whole collectible for it. The same is present with human beings. The same is present with us. We have a unique journey. We are all interesting beings, and we all have God's purpose down. But sometimes we just have to pause a little and go beyond our little threshold and figure out what more is to it. So in this campaign, I actually asked this particular question. Is my perspective the whole story, or do I need to check my bias? Sometimes we judge persons on outward appearance, how they dress, how they speak, what school they went to, where did they attend school, where did they work, and we almost form our narrative about that person, or they ended good, or she think, or he think that she's all of that, and the person is the complete opposite of our initial thoughts about them. Have you ever had an interaction with somebody that initially you had your set of thoughts, but when you get explored them, it became different? So, I mean, it exists. So we try to dispel that narrative as well. The other thing about mental health stigma is that it has some far-reaching consequences. And it further purports persons not wanting to seek mental health treatment. It further purports persons not wanting to speak up and seek support because they don't want to be evaluated or be seen as a weak person, or a madman, or use the word crazy. They don't want to be seen as somebody that is violent, because a lot of things in mental health is that we think the persons are dangerous.
Yes.
When in fact they are the actual victim because of not being understood.
Yes.
Because we haven't taken the time to understand it. And what stigma does, yes, it creates a convenient way for us to organize our lives. Everybody that has locks is smoke ganja.
Yeah.
Everybody that has a stamp in their back is probably a whore, a prostitute, or naked, or everywhere like that. We have bureaucratic, physical demarcations of what the person who should lead our country. They should have a haircut, not like mine,
Yes.
but they should have a haircut like Mr. Gaskin. I wouldn't want to listen to Mr. Gaskin because of his outward appearance, and you probably would have listened to me 20 years ago.
Yeah.
But I hope that by speaking to you today, I can help or at least promote that narrative in it to change it. So we need to dig beyond that superficial barrier, that layer. Sometimes we have to look beyond ourselves and know that in this generation, what influenced you, what inspired you is not going to inspire this generation. What I'm saying now, as a consequence, yes, they're having more substance use, engaging behavior. But what is more profound is their lack of resilience. Resilience, lack to adapt. As I was told no at my time, I found another way. And this time when they're told no, what they're doing is going to stop mutilation habits. They're probably think that they master everything, displace their anger. If they make a post on Instagram, no, and they don't get 50 likes within the next minute, I'm inadequate, I'm worthless. Because our value systems have changed, because we have spoken norms and mores and societal norms, and the shift has changed. But what's causing the conflict, what's causing the chaos, is that the older generations are certain how they were reared to this generation of how they are seeing the world. And it's a whole disconnect. It's almost like trying to communicate and no message is being transferred to our friend.
Yes, it's burning, it's burning, it's burning.
I have one question, and it's related to that disconnect that you spoke about. To what extent would the medical profession in Barbados, or doctors in Barbados using indigenous knowledge as either a preventative measure for certain diseases, or in any aspect of health treatment, including medical health? Mental health.
But you know that very often the alternate methods are basically focused on prevention. You know that for a fact. If you look at alternate methods, a lot of alternate methods are focused on preventing. If you start embarking on this healthy lifestyle, when you start using these products, you're able to prevent a lot of these things from happening. So I just wanted to put that little plug in here in terms of what we're saying about this. And I'm also acutely aware of the fact too that, and this is a challenge I have within our profession. There's this thing we say, person is non-compliant. And it's implying that you're not actively engaged in behavior practice to look after their own health. And they're labeled as non-compliant because they're not adhering to the North American pharmaceutical standard, but they're actively engaged in activity where they're using alternate methods to try to deal with issues. And I have this conversation a lot with my nursing students, that as we do our assessment of our patients, and we're suggesting that his self-seeking behavior is not compliant because he's not adhering to the pharmaceutical, but he's actively engaging in an activity where alternate medicine is working out, he's exercising, he's using his stop leave, and he's just as committed to recovery as he is. So, like I said earlier, we have to find a way to really kind of keep that conversation alive and to bridge that. But there's a movement called contemporary complementary medicine, where there's a fusion of both, and we have some complementary physicians who are also working with our clients, and some of our clients are offering to go to these persons as opposed. But and I know very often too that when persons, especially men, are diagnosed with like cancer, very often, as opposed to going the chemotherapy route and blood route, a lot of persons then are heavily invested in the alternate medicines and stuff. We all see that, right? A lot of persons, for them to get diagnosed with cancer, they opt not to have chemotherapy, those different forms of intervention. They opt to go the natural ways. But if we can get persons to really start to change their lifestyle using natural before actual disease, where the argument is happening, but you start embarking on it very early, eating healthy, and focus on prevention, where I talk about economics, it is much cheaper to prevent than cure. Yes.
Just to support before you go ahead with the question, I know that time is limited, but this question I want to ask you. So, one too often we see nurses that are involved in our federation. Right? Have you seen that here? And how would that happen?
Of course, in this area, it's not peculiar, and this goes again with, we call it imperialism. If you know what imperialism is, it's just the influences of the outside world to our small territories. So we look up to the rap culture. We want to be those persons, we want to be like money, so to speak. So we see in the videos, footballing, big chains, getting likes, getting comments. Sometimes we aspire to be those things, but we idolize that kind of behavior. So a nurse is a person first, right? So although you are a professional, I can sit here and tell you, well, I don't have to judge anything else that we do in life. What would you think it is? Look at me and make a judgment of myself. Of course. Okay, you got a physical mark. Okay, what else do you think they could possibly do? Of course. A health coach, right? So you can remain in the realm of health. I'm also in a position. So if you know blood, money, key, so what cards, how they play with that bond, and it's clear with that bond, they play with King Bubba FM, we do something that is far free from medicine. Right? And my point is that you just look at me and you just can't, you know that everything else they do going to be within the realm of health. So I never smoke, I drink. I don't drink to the point of something drunk or whatever, or that I am dependent on it. But it's a part of culture, no, that is normalized that persons engage in substance use and be evaluated. One thing that was said earlier about even using the alternative medicines is that there was an inability to quantify how much micrograms you're getting. So how do you know 3 leads or 2 leads is a dosage to make a tea with salt leads? So why is it that Jane Doe is getting a good response from drinking salt tea versus Jane Brown? We do the same thing because we have not paid credence to individuality, right? We don't know how our body constructs are. What else is going on? What else is the difference? So we look at similarity, but we need to pay attention to differences as well. All right, so I'll give the my other panelists an opportunity to speak, but please do log on to the Psyche Hospital, follow the page, and follow the campaign and be a part of it because it's for you as a society member.
All right, time is upon us, so I'm going to ask the panelists here to close with they want to regard as the most serious message, and I will give my colleague on my left to.
So my message is, if you're swimming, if you're in ocean and you're swimming alone, everything is fine. Then you look around and you see 125 or 130 sharks. Let's say you can afford 140. Now you start to panic and stuff like that, right? Because you're thinking, okay, well, these sharks are going to eat me. So take that and spin it to your blood pressure. If your systolic blood pressure is greater than 120, you understand? It's a constant greater than 120. My advice to you is to, if you don't have a family physician, have that conversation with your loved one, take a recording daily, and capture that record for 4 days, look to see if you're changing it, and when you go to your family physician, address that concern with them. Chances are you might be hypertensive, you might not should be placed on medication, but you can change your lifestyle, you can change your diet, you can get off the couch, you can walk and stuff like that. That is my message that I'm leaving to you, is just to heighten awareness of hypertension and the effect that it can have on the body. Change your diet. Sodium is your killer. Try to eat less sodium, or you can use the sodium. But more importantly, have that conversation with your family physician, talk to your family, make them aware of what's going on, and take control of your health and your life. That's my message.
Thank you.
So my take-home message today is be an advocate for yourself. When you go to the doctor, you take notes, you keep a log, you make sure that you know what's going on with you. If this week you notice something different, you write it down and you just make sure that when you go to your doctor, you speak about it. Prevention is better than cure, but most of the time, by the time you go to the doctor, we are already diagnosed. If you're diabetic, you keep a log. So you take your medication, you also do your finger stick, you keep a log. When you go to your doctor, you're able to say, over the last week, my finger stick has been elevated. Also, skincare is very important. As Mr. Gaskin said earlier, you have to take very good care of your feet. You have to dry between your toes, get a mirror look under the bottom of your feet. You will know if something is going on, because when you have diabetes, you also have neuropathy, poor circulation. But if you're able to identify something before it gets worse, you can avoid amputations, which is a high rate in Barbados. So you should be able to know this wasn't here last week, so let me go to the doctor and see what's going on. One of the other things I would say is look around in your home. See where you place your furniture. Try to take the bulky chair and place it strategically so that you would not bump your feet, because you might hit your toe, lead to another problem. So my take-home message is be an advocate for yourself. Go to the doctor, speak to them. If you find that that doctor is not hearing you, there are many other physicians out there. So you seek someone who will listen to you. And also your family members should be involved. They should know what's going on with you. If they live in the home, at least you'll be able to tell them, well, I'm diabetic. Therefore, when they're preparing the meals, they should be able to cook so that it would follow your diet. So my take-home message is Be compliant, take your medication. If that's not what's working for you, there's other methods out there, and take good care of yourself. That's going to take home message.
So very quickly, just want to say that mental health is health.
Yes.
Okay, just going to say that one more time, mental health is health. And it's okay not to be okay. What is not okay is staying not okay.
Yes.
Right? Know what your support circle is. It could be a family member, it could be a friend, it could be somebody close to you, it could even be a stranger sometimes, but they may give a more objective opinion about a situation. But beyond that, know that there are resources across the island. In every polyclinic, there is a mental health clinic on specific days. And we are gearing to get those clinics to be more treatment goals during the week, whenever Friday, so that you don't have to wait on particular days. If I ask you what's the police number, I'm pretty sure I'll you can tell me.
Yes.
The fire service number, you all know it. The ambulance service number, you all know it. What did you say, that hospital number? And there's a lot of play. So no, and she's attempting, right? Appreciate the effort. But yes, 536-3091, know your mental health care provider. We are part of the healthcare system. Don't wait until things deteriorate to a point of not knowing what do we do next. Have this advanced knowledge on what to do. It can make a difference. It can change your life. It can change your life. So please do. Mental health is health.
Yes.
Ladies and gentlemen, as we draw this discussion to a close, I want to extend a heartfelt thanks to the panelists. I want to give them a round of applause. We've delved into some of the critical health challenges facing many Barbadians, from the pervasive impact of non-communicable diseases to the often overlooked yet critical issue of mental health and preventive care. Our conversation highlighted not only the unique barriers men face in seeking and receiving adequate health care, but also the promising strategies and interventions that can make a significant difference. It is clear that improving mental health requires a multifaceted approach that includes education, community engagement, and systematic changes within the healthcare system. By promoting awareness and encouraging early intervention and fostering a culture that values and supports men's health, we can work towards closing the gap and ensuring a better health outcome for all men in Barbados. I hope this discussion has sparked new ideas and reaffirmed our collective commitments to advancing men's health. Let us leave here with a renewed sense of purpose and a dedication in making actionable steps in our respective fields to support men in our communities. Thank you to our panelists and for your time, for your contributions, and for you, a wonderful audience. Give yourself.
Is this supposed to be any fun?
All right, so now we're going to continue with the waste. If they are another million, that's all. Your question, you will take this, your number. Seven, 3, 9. Sarah Agnes. Sarah Agnes. Seven, 3, 9.
730. Thanks. Congratulations. Next, we have a date pass person and a regular member at Bristol. Seven, 3, 8. Ingrid Austin. So now we're going to for Jordan Supermarket. Seven, 4, 0. Beverly Shaw. Congratulations. Another motion for Jordan Supermarket.